Good morning, ladies and gentlemen, colleagues, friends. It's great to see so many of you here so early in the day. And Charles, you didn't say that actually there's going to be another World Hepatitis Summit coming up in Brazil. I hope it wasn't deliberately that you didn't mention it. But we really are looking forward to the second summit in Brazil. And I think that's obviously something that we hope you will all join us. I will talk briefly about the global draft strategy. It's a draft because it will only be taken to the member states in a month's time, in May, at the World Health Assembly. That's why I refer to it still as a draft, and obviously we'll hope it will be endorsed. And we are talking about elimination, so why? Obviously, and that's nothing new to all of you, of course, here in this forum, is we are talking about the seventh leading cause of death. The global momentum is really tremendously building up, and largely it's driven by the excitement around the DAs and sort of also the public attention to it. We do have the tools in hand for effective prevention and treatment, and indeed these are indivisible and both need to take place. But if we look at the reality, despite all the hype and the excitement, both at global and specifically at national level, with some exceptions, we still see inadequate country action. You may also have seen this slide, which basically shows mortality from selected conditions, and you see in yellow the mortality going up, while for many of the other diseases for which major funding is made available, HIV, TB, malaria, it is largely going down. One indicator that we measure, that we look at in WHO is to what extent really countries are moving towards systematic, I would say, planned action, and we monitor which countries are actually developing their national hepatitis plans. And you see in dark blue countries with published national plans, and in light blue countries which are currently developing plans. So in many parts of the world, plans exist. They don't necessarily mean that all the action occurs that's written into the plans, but the point I'm trying to make here really is that there are parts of the world that are still largely white. And that's basically Africa, sub-Saharan Africa specifically, even parts of Europe where we don't have plans, which is obviously here at EASL, and many parts of Asia, of course. I'm not going to talk much about Europe because my colleague Francesco Negro is going to talk about it more, but really just to say this is EASL. This is a very well-resourced part of the world, and many countries still lack national strategies and plans, data. Many patients here don't actually know their status until they get quite sick. Harm reduction as an important intervention for, obviously, injecting drug users is very variably available, and the new treatments, the DAAs, yes, they are expensive, but yes, we live in well-resourced countries, and they're not accessible in most in need in the majority of countries. So, where do we go from here? And let me come to talk about the strategy. What is the best way of framing the approach, really taking account of the SDGs that Charles has so eloquently talked about other priorities that are currently being put forward by WHO, which is universal health coverage, looking at a common structure with other strategies such as HIV, TB, malaria, and really use the strategy as a tool for countries to develop costed action plans. So I'm touching a little bit on each of those elements without going into very much detail. I will not talk about the SDGs as Charles has talked about it, but clearly we are happy that hepatitis is captured and well expressed. Maybe not well enough expressed because we are still talking about combating rather than ending, but at least there's a specific reference in the SDGs. So what do we mean by elimination? And there's some confusion sometimes because elimination is not eradication. Elimination is really eliminating viral hepatitis as a public health issue of concern. In other words, remove sustained transmission remove hepatitis, a leading cause of mortality. And that's very much in line with what we mean when we say ending HIV, TB, malaria, as is referred to in the SDGs. And clearly, even after 2030, we already know that there will be a long wave of prevalence that will remain for decades, despite all the efforts and hopefully successful efforts that will take place between now and then. So the vision of elimination is a world where hepatitis transmission is halted and everyone who needs it has access to safe, affordable and effective prevention care and treatment services, regardless of other characteristics of this individual, including wealth, geography, etc. The framing, and I already touched on it, is universal health coverage. And you may be aware that this is the overarching priority that our Director General, Margaret Chan, has put forward. And what that means is not only the access to the services, but it's really also providing that access by avoiding also catastrophic health expenditures. And that obviously is a very relevant aspect in the conversation that we have around the DAAs. Again, elimination is technically feasible by scaling up those key interventions that we have. And I think we are fairly fortunate in viral hepatitis compared to many other diseases. Some of you will ask, is this just another booklet document on the shelf? Is this just to make the UN feel better? And I would really like to argue, even though obviously I might come with a bias here, you will say, but we can use a global strategy, and we have used in other instances global strategies as really very powerful tools for mobilizing resources in action. And again, HIV is an example that might sometimes be overstretched, but HIV is a good example where a strategic discussion and a strategic strategy document has helped really to trigger action also in countries, get countries engaged and account for what they owe to their citizens and what they have to deliver to their citizens. It is also a way to not only say we have to do something, but it also specifies what the something is. It helps to find agreement on what the action is needed to reach the targets. And obviously, it should not only be a global conversation, but it needs to filter down into regional action plans and ultimately into country action plans. And in Europe, we are having already a European action plan that's under development that was discussed with member states in Copenhagen just last week. So numerically, what do we really mean by elimination, and what is the impact that we are hoping to achieve? We are talking about, obviously, reducing incidence and reducing mortality. These are the two impact parameters that we are talking about. And let's assume we have up to 10 million infections in 2015. We want to reduce by 90%. We do not want to have, by 2030, more than 1,900,000. It's still a lot, still way too many, but it obviously constitutes a major reduction. In terms of mortality, we have more than 1.4 million people that died in 2015. We want to use for hepatitis B and C the treatment options and cure options that we have to reduce mortality. Despite all good intentions, we've done a lot of modeling to push this further down, but what we see is realistic, ambitiously realistic, is a 65% reduction here. So what are those key interventions? You're obviously an audience that knows all that. We have prevention intervention, Hep B, safe injection practices, harm reduction, safer sex practices, including condom promotion, and then we have Hep B treatment and HCV cure. Nothing new to you, of course. But what is a bit newer is to really see, so what are the coverage targets that we need to aspire to so that we can actually achieve that impact in incidence and mortality reduction that I just showed you. The baseline on the right-hand side, Charles already talked about it, doesn't really look great with the exception of HPV vaccination. All the rest is fairly meager. 2020, an important milestone, also very much in line with the time frame of the strategy, more or less. And then 2030, the elimination targets, and these are the coverage targets that we hope to achieve. 90%, 90%, 90% for all the prevention stuff, and then 80% for treatment for HPV and HCV. And there's one figure that I would really like to highlight. That's the 8 million people that we hope to have treated by 2020. And 8 million is just actually 10% of those who need it. But from where we are, it is obviously a big jump. And it would mean 5 million in HPV treatment and 3 million HCV treatment/cures. Here's the global strategy, basically in one slide. What's in it? And you will see the vertical boxes here, which basically are the 5 strategic directions that talk to, one, information. What information does a country need to develop an action? The what intervention should be delivered? The how can they best be delivered? Strategic direction 4 is, how can a country actually think about the best ways of financing, a very hot and very relevant issue in basically all countries? And then strategic direction 5, what innovation needs to happen in order to achieve greater impact? We've done some modeling in sort of basically saying, if that strategy is fully implemented, what would be the gains in terms of averted mortality? And you see that there are more than 7 million deaths. I'm from Austria, it's about the population of Austria, would be prevented by 2020. So it's really an incredible gain that I think we should be talking about when we try to convince policymakers and program planners. It doesn't come for free, of course. And we've also done the costing. And we've costed the various interventions. You see basically all the prevention interventions at the bottom. And then you see screening and hepatitis B and C treatment, which basically are the major cost drivers in that strategy, not surprisingly. And we've already factored into all of that costing exercise some major cost reductions. But still, compared to many other expenses in the world, health expenditures and others, it peaks at $5.2 billion in 2026. So the cost will go up gradually as we scale up the interventions, and then cost savings will kick in, which is what we obviously are also looking for. And you will see quite some dramatic cost savings as we move towards 2030. This is only for low and middle income countries. This does not include the high income countries here. One of the important discussions that we always have when we have to talk to ministers of health and finance and basically those who have to make decisions in countries is this cost effective? Is it cost saving? And how quickly can I actually save money? Without going into all the details that are on this slide, but basically we have all the evidence to show that the prevention interventions are highly cost effective. Okay, and that includes harm reduction. When it comes to treatment, obviously, cost itself is a major factor in determining cost effectiveness. And just to show here the estimated costs of selected DAAs in 2015 and the regimens in Brazil, Mongolia, and Ukraine. And you see in blue the PEG-RIVA costs and in red the all DAA costs. The point I'm trying to make here is in several countries, and I think Brazil, probably in the newer data, it may already be lower, DAAs have become cheaper than the traditional the standards of care a few years ago. And that, I think, in it itself is an important conversation to have. But I'm showing you now 2 slides from China because we have worked specifically with China on an investment case, basically, again, to convince the Chinese government to make that major front-loading investment that will be required. And what we are showing here is to what extent HPV treatment with tenofovir could be cost-saving, highly cost-effective, or cost-effective, the different shades of blue. And China has been very successful in negotiating the prices down for tenofovir for HIV, and it costs $360 per year. And if it comes to hepatitis B, it's 10 times more expensive, close to $3,000. So the point we are trying to make is we have to move away from this red bar to the green bar for hepatitis B, and it will be cost effective. It will be actually highly cost effective. For Hep C, basically we are comparing current practice in red with the DA regimens, and we are looking at what the cost savings would be over time. And we even see that within a 5-year time window, we would have some cost savings already, but that this cost saving, the green bar, is really going up in the 10, 15, and 20-year time window as we move towards 2030. So an incredibly strong argument, and that's based on an assumption that the costs would be brought down to $900 per 12-week course of sofosbuvir. Another important issue is what can we learn from HIV, and here just the point is we have to start thinking of how services are delivered and how we can move out of the big hospitals, tertiary care centers, towards more decentralized care, because that's another important area through which we can save costs. So, elimination by 2030, what it will take? A lot of energy. And I'm really, really happy to see that at EASL, I've been at a couple of EASLs now, there's more and more attention to access, to really scaling up the national responses, discussion of elimination, the joint statement. It's fantastic what's happening. Commitment, and of course resources. We'll really have, from a very individualized approach, to move to a public health approach, as we have been seeing in other disease entities, simplification, integration, decentralization. Radical reduction in costs. We have some very positive examples already, but we need more of it. Innovation. We still have a lot of work to do in the area of diagnostics specifically. We're obviously looking towards HPV cure, etc. Partnerships. Nobody can do it by him or herself. We'll have to work together. You all, clinicians, researchers, governments, civil society, the private sector, pharma has an important role to play. And ultimately, what will count and what will make the difference is concrete and tailored action in countries. And again, coming back to where I started, we do hope that the strategy will be endorsed by member states, that governments will buy into these very ambitious but very relevant targets, and that this strategy can be used as a tool for assisting them and actually pushing them towards greater and more decisive action. Thank you very much.